Well, welcome to this video. We're going to be looking at information from the UK today, but it's going to apply to wherever you live. The principles are going to be the same. Hard to give a bottom line to this video really, but I'll give you perhaps the main one. The infection fatality rate, that is the proportion of people that were dying in the UK compared to the number that were infected at the peak of the UK pandemic, which is March-April time. The actual infection fatality rate was probably about 0.56%. So about one person in 200 infections dying at that time. Now, in a sense, that was artificially high because the infection got into care homes with vulnerable people there and probably killed a disproportionate amount. So the good news is we're expecting the infection fatality rate from now on to be somewhat lower than 0.56%. No guarantees, but I think the reasoning is fairly good in this. And the other thing that I want to really stress now is it's young people that are driving this infection mostly at the moment in the UK and indeed throughout Europe. And when we look back into March, April, there was long lag times between people spreading the infection and people eventually dying. We could be talking about 4, 5, 6 weeks delay time. And that kind of takes us into autumn, which is a bit of a concern because we need to get over this winter before we are liberated. I believe we're going to be liberated by vaccines next year. So that was the position in the UK. We see these numbers increasing here. And these numbers are reasonably accurate just now, whereas these numbers here were gross underestimates. And I strongly suspect, I haven't got data to prove it, but I suspect the situation is the same, where in Spain and France at the moment, these increasing numbers that they're having, while they appear, so for example, that's the Spanish peak there, that's the number of cases in Spain now. It appears that the number of cases in Spain is higher than the peak, but in actual fact, there's a lot of reasons why the real number at that peak was probably quite a bit higher than that is now. So that's kind of the bottom line of this video, but there are principles that I believe can be really useful for all of us. Now let's dive into some of the detail. So the UK now, the COVID symptom tracker app is saying 2,600 new cases per day. The actual number in the past couple of days has probably been about 3,000 cases per day, but of course the COVID symptom tracker app underestimates the real number because it only picks up the symptomatics. We really need to add another 20 or 30% onto that for the people with asymptomatic infection. And the COVID symptom tracker app is saying that 29,000 people in the UK currently have symptoms. Now, look at our world in data. I'll be giving you the reference for the COVID symptom tracker app as well. Lots of interesting stuff in that. Now, this is where the reasoning kind of begins. The UK lockdown was on the 23rd of March. So now the new cases are around about, that was the last figure I had there, 2,200. We know it's now 2,605 new cases officially per day, probably slightly more than that. That's the number of new cases now per day. But now we're testing 170,000 people per day, whereas at the peak of the outbreak, as we saw, just remind ourselves. Where am I? There we go. So here, this is the situation now at the peak, where we seem to have just under 5,000 cases per day. We're only doing 65,000 tests a day, and they were in hospital. They were picking up the more poorly people. So there we've got about 65,000 tests per day. Now we've got 170,000 tests per day. So this is a more accurate figure. The lack of testing here means that these real numbers are significant underestimates. But there's other factors as well as that we're going to come on to. Now, So yeah, that's the number of tests being done now. The number of tests being done at the peak, only 65,000. Now the next bit, I've had help from local scientists and mathematicians, Rebecca Hanson and Andrew Bayliff, who've helped my thinking on this. I just hope I can explain it to you and haven't misrepresented what these people have helped me with. Now, there was a lot of unknowns, of course, during this first peak. A lot of things we didn't know at this time. We just weren't geared up to know a lot of that information. So what didn't we know? Well, most of the testing was done by people in hospital, so we didn't know what was going on in the community. It turns out there was a lot of people who almost certainly had the infection at that time, a lot more than we were picking up with testing. We can't really go back and check because the antibodies only last 10 weeks and the time's expired, and significant surveys weren't really done till early August. Now, we could work out the real numbers with T-cell tests, but they're sophisticated, they're difficult, they're expensive, and that's not going to be done anytime soon. Now, a lot of the data I'm going to be talking about now comes from the Zoe Symptom Tracker app, which you have the link for in the description. You can spend ages on this. You can zoom in and get lots of interesting things about your area, the number of cases and what's going on. But that's not the main point I want to do today. That's more geographical information. That's the number of new cases per day at the moment. But this is interesting. This shows the day-by-day evolution of the infection across the UK. And this is the number of people calculated to have COVID-19 at the moment. So at the moment, there's about 30,000 people. That actually says 29,022 there. Actual people complaining of symptoms, and we know there's about 3,000 new cases per day, and if the symptoms last for 10 days, of course, that makes perfect sense. But we see the way that the numbers have come down. This is all the time we have very accurate data for on the COVID Symptom Tracker app. From 90,000 people sick on the 11th of June, coming down nicely, gone up again a bit now. We're a bit concerned about what's going to happen here, especially with the onset of the cooler weather, especially with schools and universities going back. This is the current concern. But what this data is based on is this animation. It's very clever. It works it out for all the parts of the country. But what we have here, this is the end of March. So this is April here, and this is May. So what we see at the beginning of April, and these are weekly data points that are coming on here. And we see it's going up slightly now. But what we notice is here, that data point there is for the 1st of April. And it's well over 2 million people were symptomatic in the UK on the 1st of April. That is a lot of cases. So that's a lot of cases of people that had symptomatic disease on the 1st of April. Now, this is the best data we have because, as we said, the antibody data is now lost to history. We can't work this out another way. And we know that the cases diagnosed were in hospital. I mean, what you probably remember, but at that time, there was a great shortage of test kits, and testing was restricted for people who needed it on clinical grounds. So it was only picking up the most poorly people. The vast iceberg of people that were being infected in the community simply weren't being picked up by testing. But fortunately, they were being picked up by the COVID Symptom Tracker app. Now, the lockdown was the 23rd of March, just before then, and cases kept on increasing for that 8 days or so, up until the 1st of April, and then we had this exponential reduction in cases. That's when the lockdown started to kick in. Now, so the 1st of April, the prevalence is the number of people who have the infection at any one time, was about 2.1 million cases from the COVID Symptom Tracker app. So this was the cases that had presented after the incubation period from the start of lockdown on the 23rd of March, over 2 million cases. 2 million people with active symptomatic disease in the UK. Now, if we make the assumption that the symptoms last for about 10 days, which is not unreasonable, it's not unreasonable. That means the incidence, which is the number of new cases per day, would be round about 200,000. That comma shouldn't be there. 200,000 new cases per day, roughly. But we now know that at least 20% are going to be asymptomatic. So we have to add 20% to that. So we get something like 240,000 new cases on the 1st of April. This is a frighteningly large number, 50 times more than the 5,000 or so officially diagnosed. And even this number is an underestimate because we have to add more for the symptoms that we now recognise that indicate COVID-19 infection. So, for example, at this time, we weren't really aware of the anosmia, the loss of smell. We weren't really aware of the rashes and the COVID fingers and toes that go with the rashes sometimes. So more symptoms are now being recognised. So again, that means that this number of cases, this 240,000, is an underestimate. Basically what it means is it's very likely that on the 1st of April there was 250,000 new cases per day before the exponential drop-off as a result of the lockdown effect on the 23rd of March. Now, the peak deaths in the UK came, as you would expect, a fair bit later. They came on the week ending the 19th of April, which was week 16. And for the UK, this is the UK as a whole, including Scotland, Northern Ireland, Wales. The Office for National Statistics state that COVID-19 was involved in the death certificate of 9,500 people. And actually, that's a bit of a delay. So that will be from the week before. It was involved in the death certificate. Check it out there. That's the reference there. So about 9,500 people died of COVID-19 that week. That works out, if we take the average for the week, at about 1,350 deaths, 1,351 deaths per day of COVID-19 at the peak death period, the week leading up to the 19th of April. So I hope you're with that so far. Now, what this means is the peak case fatality rate. So if we take the diagnosed cases, that was the number of diagnosed cases. That was the number of deaths. That gives us a case fatality rate of 27% of people dying. Now, we never thought it was that high. We always knew it was lower than that. But figures of about 6 and 7 and 8% were talked about at the time. For Italy, it looked very high. It looked about 12% for Italy for quite some time, I remember. Now, we knew it wasn't that high because we knew we were greatly underestimating the amount of actual cases, but we didn't realise how much we were estimating the number of actual cases. So from this, and this is absolutely fascinating, if the real number of cases was 240,000, which we now suspect it was per day new cases, and the deaths were 1,351 per day, as they were for that peak week of deaths. So we're accounting for the cases, then we've got the 2-week delay, and then we've got the deaths. So we've accounted for the delay. That gives us an infection fatality rate of 0.56%. So it looks like the infection fatality rate in early April in the UK was 0.56%. But even this is somewhat artificially high because what happened is we kind of messed up and we let the virus into care homes where there's a lot of vulnerable people and the infection spread very rapidly, and that greatly increased the death rate. So even allowing for that, it looks like the infection fatality rate then back in early April was 0.56%. So, how does that compare with more modern estimates? Well, we looked at this just a few days ago, actually, estimating the infection fatality ratio in England. Again, it's always a bit out of date, this official data. Quite a bit out of date, but it's the latest figures we've got. So the Office for National Statistics estimate the death rate at 0.49%. This is overall since the infection began. And the Centre for Evidence-Based Medicine in Oxford estimated at 0.3%. So not too far out of this way of estimating the 0.5% infection fatality rate in early April. And in actual fact, this could be right because the infection fatality rate is dropping over time. So because the infection fatality rate is dropping over time, that would bring this average down to these kind of figures. So we expect the infection fatality rate to be in this range or perhaps even slightly lower. So in other words, what we see is we massively underestimated the amount of cases in the early pandemic, probably by about a factor of 50. So early April, there could well have been 250,000 new cases per day, but 1,351 deaths a couple of weeks later as a consequence of those infections, giving a much lower infection fatality rate. And we saw that exponential drop-off as a result of the effect of the lockdown. So this is fascinating because it gives us an insight into the actual infection fatality rate. And also, was the lockdown a good idea? Well, I think we've concluded from that information that yes, it was. Without the lockdown, the exponential growth would have carried on upwards rather than downwards. Perhaps 40 million people would have been infected. Now, there would be less deaths, perhaps, than that infection fatality rate because there'd be a lot of young people. But there'd be more deaths because the NHS would be overwhelmed. 5% of people would have got sick. 5% of 40 million is 2 million cases. 2 million people could have been seeking healthcare pretty well all at the same time. And I just wouldn't want to think about that at all. Many people would have died as a result of that. So what we're seeing is this lockdown caused exponential decay in the number of cases. What we're seeing is the actual infection fatality rate is way lower than it looked because we massively underestimated the amount of cases. Or we got the amount of cases right, they're the ones we diagnosed. We massively underestimated the amount of infections. So 0.56 is looking much more accurate for that period of time. The overall average now is 0.3 to 0.4, and that hopefully will continue to drop, especially now we've got better treatments available in the healthcare sector. Now, at the moment in my local hospital, as of yesterday, there were no cases of COVID-19. Quite amazing, there are actually no cases. But we know that infection is spreading at the moment in younger people, and we're concerned because schools are going back and universities are going back. Now, the infection drivers in some parts of the UK about a month ago, as we looked at in the local lockdowns in Manchester and Lancashire and Yorkshire, that it was family visiting. In fact, one family visiting another that was the infection driver. So that was able to be curtailed with local measures. At the moment, it's young people, mostly socialising, that are driving the infection. They're going to take it home to older people, but that's going to take another week or two. Then older people might transmit it, say, from parents in the house to grandparents in the house, or grandparents to visit, for example. That could take another week or two. Then, of course, grandparents have to incubate it. Then, of course, they have to get sick. Then they have to get more critically sick, and then they have to die. If they're going to die, hopefully they won't. So we see we've got this lengthy lag period, and that's taking us into winter time. And that is what concerns me. So if this is well managed and we take all these precautions that we know about, we take all the public health precautions, the mask wearing, the hygiene, the distancing, all those sort of things, we won't need, I don't think another lockdown is going to happen, to be quite honest. But we've seen the effect of the lockdown, and we've seen what would happen if we didn't have the lockdown. So we see that the public health measures are absolutely crucial. So this next few weeks is actually a crucial time when we have to reduce the drivers of infection, and at the moment that is primarily young people in social situations, and could get way worse as universities go back, because we just have to get over this winter, then things are going to be much better. So kind of good news and bad news there. There's a bit of a warning, but the good news is the infection fatality rate seems so much lower than we had thought it was, and that's now collaborated by different ways of looking at this. But of course, that all depends on keeping the number of infections down, keeping the number of hospitalizations down, so that we're able to treat everyone that needs treated. And of course, the wonderful thing about having our local hospital at the moment COVID-free, we're still all the precautions are still being taken, of course, but it means other people can be treated, so that we won't have this sort of collateral damage, people that were untreated because we were too busy treating COVID-19 patients in the past. So that's this video. Lower infection fatality rates, but we've got this winter to get through. That's what I wanted to get across today, and it just shows how wrong people got this in the past, but we are seeing it much more clearly now. Now that's this video finished. I'll just show you, I got a video clip from Brazil where they're doing, as it says, COVID-19 immunoglobulin type G and immunoglobulin type M rapid test device, and of course we need huge numbers of these. Let's just see it in use. I think we can see it in use. No, we haven't quite got there yet. Oh, there we go. Let's just go back a bit. There we go. It's just a finger pricker device. We use these all the time, which is actually hasn't got a very good sample there, so it looks like she's going to have another squeeze. Good, looks like we've got a drop of blood. Remember, the antibodies are the immunoglobulins, the immunoglobulins are the antibodies. The key thing with these drops of blood is not to smudge it, so it keeps all in one drop. If you smudge it, you just can't get your sample at all. There we go, we've got a sample now. Putting it onto the test meter at the bottom. Now she'll need some reagent, that's good. Then what happens is it'll rise up here to give the result of that bit.
Agora espera 20 minutos, né? 20
Oh.
minutinhos.
I think we can see the next bit.
Cassete, ele tem aqui escrito o Czinho, o IgM
Oh,
e o IgG. Esse IgM, tá vendo? Aqui ó, escrito aqui ó, IgM e IgG.
Oh, she's zoomed in there. So we've got the IgMs first and then the IgG, and that top strip there is the control. So this is actually, let's just go back and look at that. This is actually negative. So there's no Ig. Is that Ig? Can't quite see there. Anyway, there's no immunoglobulin there. There's no immunoglobulin line there, but the control is working, so the test is okay. So that person actually appears to be negative.
Tá. São dois
For
anticorpos
the
que a gente
antibodies,
produz
they are
quando a gente tem
antibody
contato com
negative.
vírus. O primeiro
And I like the way they
quando
actually
você
keep
tem uma
these things in the
contaminação
notes, so
recente, está em processo infeccioso. Então
everyone
vai
can
indicar
see
que você provavelmente está contaminada com o vírus.
what the result
Já o
is. It
segundo,
takes
ele é
away
anticorpo mais
the
tardio.
ambiguity.
Então, você pode ter se contaminado já ter uma
Okay.
imunidade, certo? Então pode
E
ser
nesse
que você
teste
não
sai
esteja
os
nem-
dois?
It is, isn't it?
Isso, pode ser que dê só o IgG
Okay.
ou
So
só
all
o
we need to do now is this is a picture of who is this? This is Lisa, and her mum is Jean, and her mum Jean has been watching the videos apparently right from the start. So they definitely deserve a mention for watching for such a long time. And I think Lisa might live in Seattle, but I'm not sure. Okay. That's us for this video. Thank you very much for watching.